Good afternoon, everyone. Welcome to the Independence Age briefing. It's more than 2 years since the pandemic began, and Independence Age has been going for most of that time, is still around and operating with the same drive and passion as we have throughout the pandemic. And the importance of this is that, first of all, COVID is still causing disease. It's still causing concern for the vulnerable within the population, as well as having, secondly, a number of unexpected and indirect consequences we're only now starting to understand. And those consequences are also to the detriment of many of us. And thirdly, of course, we've got to learn the lessons from this pandemic, learn how to have a public health structure which is sustainable, is robust, and of course can prepare us for the next pandemic. So many reasons why we're still going. And of course, in recognition of that, we're dedicating today's session to you, the public, to take as many questions as we can and address them in the best way that we can. But before we jump to the Q&A session, I'd invite Dr. Duncan Robertson to share with us the latest COVID data. Over to you, Duncan.
Thank you very much. So we're in summer and we're sort of coming out of this BA5 wave. So we're seeing infections, hospitalizations and people in hospital falling. However, we're seeing the pressure on the NHS, particularly in health admissions to hospitals and ambulance data. Also look at some of the vaccination uptake so far in children prior to thinking about going back to school. And also I'll talk give some information about excess deaths. So these are deaths from all causes over the period of the pandemic. So let's go and have a look at the data. So this is what we're going to be looking at today. So let's have a look at infections. Now, ONS haven't published their data this week. So if you remember, ONS is the survey that's done randomly, asking people or taking swabs to see if people are testing positive for COVID. They haven't produced data this week because they're changing the way that they collect the data. Of course, some of this is due to the frequency of data and the amount of data that's collected and the way it's returned. So they're just kind of doing some checks on that, but data will be back next week. So it's still a weekly survey. It's just this week it's delayed. But if we look back at the data from last week, we can see that we're definitely coming out of the BA5 wave. So you see for all of the countries of the UK, the number of people who are testing positive is falling. So that's a good thing. What's not so good is the hospital data. So what is good, is the number of people in hospital and people being admitted to hospital. So that's good. So that's falling in a similar way to the number of people testing positive for COVID. It's obviously delayed a bit, but it's still admissions are falling. So this is a fall at the end of the BA5 wave. And of course, as well as number of people going into hospital, the difference between number of people going in and coming out is the number of occupied beds, and that is also falling. So good news all around, and particularly number of people in mechanically ventilated beds, that's also falling, perhaps at a slower rate, but we still have 200 people who are occupying those mechanically ventilated beds. So what's not so good, this in terms of hospitals, is their performance indicators or key performance indicators. So if we look at the number of people or number of patients who've waited more than 4 hours from arrival to being admitted or transferred or discharged, we can see that number is creeping up so to 29%. So, really significant number of people having to wait significant periods of time in A&E before being admitted or being seen effectively. If we look at this over the years, so this is, we've got 4 lines there, 2019, 2020, 2021 and 2022 at the top, and we can see that is increasing over time. So the thing to remember is that we're in the peak of summer. Now, of course, we do have pressures due to heat waves, etc. But generally, in previous years, we've seen a dip in the number of 4-hour waits over the summer period, whereas now in the middle of summer, we're seeing that increase. So, signs of significant pressure there. Number of people who've waited more than 12 hours from the decision to admit to actually being admitted, you can see that's going up significantly to 5.9%. And this is something that, really is having a huge effect, as can be seen if you compare that to previous years. So it's really a significant outcome of pandemic pressures. And if we look at a number of people who just leave A&E before treatment is completed, around 1 in 20 patients are leaving before treatment is completed. So as you can see, that's a significant increase over the period of the pandemic. These are cancer waiting times. And once again, you can see there's a significant increase in those. We have a target of 7% waiting longer than 2 weeks to see a consultant following an urgent GP referral. And now we're significantly above that. And this, what's not good is the trend is upwards as well. So, this obviously has effects not only in mortality from COVID, but also has indirect effects. So we'll talk about at the end of the presentation how we can look at what those figures are. And more than 2 months for cancer waiting times, that's also increasing significantly. So patients waiting longer than 2 months to start treatment following an urgent GP referral, and the trend is also upwards and very significantly above the target. So on to ambulance data. We're seeing a trend upwards in the number of in the time taken for responses, particularly in the category 3 and 4, which are the least urgent categorizations. But we're seeing increases in all categories of ambulance delays. And I think what's perhaps most significant with this is to look at the category 1 data. So we have a target there of 7 minutes, and this is starting to creep up as well. So there's some argument that you can have category 3 and category 4 weights increase, although there's potential for harm, but there's more significant potential for harm when you have these category 1 cases being delayed. So this is also a significant problem. On to vaccinations, particularly looking at children's vaccinations, as people are thinking about the return to school. So this is for 16 and 17-year-olds, and of course these were some of the first children to have vaccinations. We still have a significant number of people or children in this age group who are unvaccinated, and that does vary between UK country. So Scotland at 19% unvaccinated, Northern Ireland at 32%. So, a significant variation there. But the majority of 16 to 17-year-olds have at least had one vaccination. Looking at 12 to 15-year-olds, you can see that actually there are more unvaccinated there, between 33 and 51%. So in Northern Ireland, roughly half of 12 to 15-year-olds have not been vaccinated at all, and this, is an issue. And in the youngest age group, who are eligible at the moment, we can see we have very high number, or a minority of those 5 to 11-year-olds who've had their first vaccine dose. So, potentially as we return to school, there's protection that could be there by having vaccination that that is not being done, but perhaps could be if there was a drive for back to school vaccinations. Looking at variants, as I say, we're the red in the top right there, so this is time from left to right. We have the BA5 wave. We're very much in, that's dominant, and we're not really seeing at the moment in the data we have a new variant come along at the moment. It may be there in the background, maybe they're kind of hidden away in the data, but it's not significant so far. So there's no sign of a new variant wave at the moment. And we can also see, we have these Omicron wave, Delta wave in green, and then repeated waves of BA1, BA2, and BA4 and 5, particularly BA5 at the moment. So we can see these waves. So this is the proportion of sequences that test for each of those variants. So we're really coming out of this BA5 wave. So even though we have most of the sequences being BA5, the number of cases is falling. And I thought we'd spend some time just thinking about excess deaths. So this is data from the Office for Health Improvement and Disparities. So if you recall, what was Public Health England was split into, just in general terms, into UKHSA, who do things like the dashboard, and the Office for Health Improvement and Disparities, who look at how health can be improved. So a function which used to be part of Public Health England. I'm going to be showing some charts, but just to make sure that you look at the vertical axis, so the y-axis. The axis isn't the same on each chart, so just be aware of that when you're looking at the data. But first of all, what are excess deaths or excess mortality? So this is data for England, and this is looking at the number of deaths. So of course, a significant number of those deaths will be COVID related, but of course there will be other indirect causes of death that could be related to the pandemic, particularly due to number of excess demand in the health service. So what you can do, instead of looking at the data for COVID deaths, which perhaps is best explained by the number of mentions of COVID on the death certificate, this is looking at all deaths. So it doesn't discriminate between what the cause of death is. It's just counting the number of deaths. And then what you can do is you can sort of compare the number of deaths in, say, 2022 to the number of deaths you would expect. And the number of deaths you would expect is modeled using the data between 2015 and 2019. So you can see what you would expect if there hadn't been a pandemic, and you can compare that to the number of deaths that we actually show. So this is, the data quality is excellent because deaths are, of course, very well regulated. So this is the excess mortality in England. So this is all deaths over from the beginning of the pandemic, or at least the beginning of when data was really collected about the pandemic. So the end of March 2020 up until a couple of weeks ago. So generally, in general terms, this follows the kind of COVID wave. So we're seeing excess deaths, particularly in that first wave, and then seeing subsequent deaths over subsequent waves. However, we can see actually there's some negative figures here. So actually that's negative excess deaths, which is also not a bad thing, put it that way. So in terms of, and there's a lot of split in terms of how this data is analysed. So for example, you can see this is care homes. Particularly in that first wave we had a significant number of deaths in care homes, which of course has reduced over time. But we had, of course, the very significant issue with care homes right at the beginning of the pandemic. So one thing that has happened is excess deaths are happening at home. So people may not be going to hospital as much, or indeed going to care homes as much. So we are seeing the number of deaths at home significantly increase over the whole period of the pandemic. And this is the number of deaths in hospital, but generally that follows the COVID waves. We can look at the place of death and summarize it here. And so we can see actually the number of deaths at home is significantly higher, number of deaths in hospital is significantly higher. Number of deaths in hospices is significantly lower, but you can see home deaths are significantly higher. We can look at deprivation, and the way we look at deprivation is we split the population into 5 groups. We call Index of Multiple Deprivation, or IMD. IMD1 is the most deprived fifth, or 20% of the population, and the IMD5 is the least deprived fifth, or 20% of the population. So here we can see, once again, following the COVID waves, so that's for the most deprived, and this is for the least deprived. Now, it doesn't really look that different until you actually look at the number of people who have died in each of those. Now, of course, IMD1, IMD2, IMD3, IMD4, and IMD5 have the same population in them. So we can see that actually we are getting excess deaths in the most deprived groups compared to the least deprived groups. We can look at age groups. So this is looking at how many excess deaths there have been over this period. And of course, these aren't just COVID deaths, these are all deaths. So particularly in the oldest age groups, and perhaps less in the 0 to 25 age groups than we would expect. Now, of course, there are different numbers of people in each of these age groups, so you can't really compare them directly, but you can see actually if you look at how many more times deaths have been in each of these age groups, we can see 50 to 64-year-olds have been significantly higher number of deaths than we would expect. And that is played out in the excess death data for 50 to 64-year-olds. So you can see almost every time period, we're having excess deaths in the 50 to 64-year-old age group, which I think is of note. And then this is 85 plus, which, as we can see, more mirrors the pandemic, whereas going back to the 50 to 64-year-olds, we're seeing right across the time period. And ethnic groups. So this figure on the right, so even though we've had a very large number of deaths in the white ethnic group category, there are not more people in that category. So the way we can look at that is to say how many more times deaths would we have in each of these ethnic group populations. And so we can see white have had about 1.1 and Black Asian have had about 1.3 times. So significantly more in Asian and Black ethnic groups than would be expected. So we can see that there are disparities within ethnic groups as well. So there we are. That's what we have. To summarize, infections are falling, hospitalizations and people in hospital are falling. There's pressure on ambulance services and the NHS. Vaccinations in children is low prior to going back to school. We've peaked in the BA5 wave. There's no clear sign of a next wave for now. And was looking at some of the commentary on excess deaths. So thank you very much.
That's really, really interesting, Duncan. Thank you very much. I particularly enjoyed or alarmed of your analysis of the data on disparities and excess deaths. And clearly there's lots to be discussed and analysed for future. But if anything, it exemplifies the long-term consequences of the pandemic, on top of course, a society and public services which have very differential impact on different groups, the discrepancy in wealth and so forth across the UK, which was the situation that we found ourselves when COVID hit. I think we're now understanding what the impact of that is. So thank you very much, Duncan, for that. So let's move on to questions. And thank you for the public who are with us. We'll invite those of us who are online to ask their questions, and there's some that I'll read out, and I'm sure we'll give our panel a good run for their money looking at some of these questions. So to start with, do we have Andrea Dobrowolski on the line who can unmute and ask your question?
Hello,
Andrea.
can you hear me?
Yes, Andrea, can you hear us?
Yes, I can.
Yes, please fire away.
Yes, I've got two questions. The first one is, what is the state of the pan-coronavirus vaccine development?
Okay, thank you, Andrea. That's a great question. And before we come to the panel, there's people I think have different perspectives on this, whether we're talking about COVID variant vaccines versus true pan-coronaviruses of all the coronaviruses that infect humans. But to shed light on this, can I ask Steve Griffin, Dr. Steve Griffin, to put something forward?
Sure. Thanks, Andrea. That really is a very pertinent question, especially as we're seeing such diversity in the variants that we're talking about. And Deenan's right. I think the biggest challenge that we face at the moment is to have a vaccine that will protect us from what has happened and what may happen in terms of SARS coronavirus 2 evolution. And the issue that we have is that at the moment, vaccines are primarily targeted against the spike protein, which is the protein on the surface of virus particles that gets the virus into the cells by binding to ACE2 or some other receptors. And the problem is that protein, whilst coronaviruses mutate at a fairly normal rate, the protein's able to adapt to these changes that it sees, and changes quite dramatically in terms of the shape that is recognized by the antibodies that we raise in response to either an infection or a vaccine. So hitting spike really is like hitting a moving target. And as we've seen with Omicron, started with Delta really, but now Omicron is so antibody evasive that we really are finding reinfections becoming a problem, and of course lots of susceptible people as well in the population. So what we really need to do is to target our vaccination programs towards regions of the virus that are less variable, okay? Now, there are parts of the spike protein that don't vary as much in this particular S2 domain, which is sort of the mechanical bits of the spike which actually mediate punching through membranes. So there's been some success looking at that. There was a really nice paper in Science a few weeks ago about that. So that's one option. You could also target areas of the virus that perhaps aren't present in that virus particle, which would be more of a T-cell vaccine, which would stop us getting severe disease. They tend to be less variable. But there are other parts of the virus particle that we might think about putting vaccine research efforts into as well. So there's lots of options there, and lots of different groups are looking at these different ideas. The problem that we have is this constant regurgitation of waves that we have with the virus, and having to be able to keep up, because we're already seeing that the Omicron trials are already out of date. So what remains to be seen is whether we can get this done quickly and effectively and in a kind of future-proofing kind of way.
Thank you very much, Steve. That was a great answer. Andrea, you said you had a sort of follow-up question. Is that right? If we can make
Yes, there's a different question. I wanted to ask, is enough public money invested in research regarding vaccines and medications, both for acute and long COVID?
Wow, well, that could take us all day to discuss, because there's a lot in there about the infrastructure we have in the UK and but also globally. But does anyone want to briefly comment on investment in vaccines? I mean, there has been, of course, there's major concern, I think, that the COVID vaccines is seen to have done its job. The companies that have made them have taken away their billions in money without distributing at low cost, and that's it. So I think it is a reasonable concern. But Steve, you want to come back?
Sure. Sorry to hog the floor, but I think it's a really important point. Traditionally, governments across the world have allowed the sort of end stage development of those therapeutics and vaccines to be very much within the remit of pharmaceutical companies, because they're the only ones prepared to take that financial risk of running trials and developing things and all that sort of stuff. And they're the only ones that have the infrastructure to do it. But the consequence of that is that, of course, pharmaceutical companies are businesses. And so this is why we have these struggles with allowing access at reasonable prices and things. And if you just look at the scale of the cost of this pandemic, it really strikes me that the government's investing more in worldwide vaccination centres or programs like Gavi. There's no real equivalent for antivirals. There are smaller operations going on with that. But that sort of investment would really pay for itself if they were so minded. There are schemes, but they're not on sufficient scale. So we are reliant on pharmaceuticals. And until that cycle is kind of broken, or at least balanced out, I'm afraid we're going to be in this situation and for the foreseeable future.
Thanks, Steve. Yeah, Susan, please come in.
Thanks. I mean, I suppose what I want to say is something more general about medicine generally. I mean, often there's just not enough money put into prevention. Sometimes there's money, yes, there should be more money put into all of these things in terms of healthcare and social care, but often a lot of money is put into pharmaceuticals of various kinds, like therapeutics or vaccinations. And it's the neglect of more simple things that can prevent the problem to begin with. So very obvious things that we talked about a lot on this in these sessions is ventilation, changing infrastructure so people don't get ill to begin with, so you don't need to invest in the looking at long COVID, making sure that people have financial support for isolation. If people are in crowded indoor spaces and they can't afford face masks, that those are supplied, as other countries do. So I think when one's thinking about investment to maximize population health, it's really important to think of the whole system and think about prevention as well as the therapeutics down the line, because if we could prevent more, we wouldn't have to have so much investment in making things better down the line.
Thank you very much, Susan. And Andre, you've obviously stimulated a good discussion, but thank you very much for your question and coming on in support of Independent Sage. Okay, thank you. So we move to the next question from Hilda Palmer, who I think is here from the Hazards Campaign. And I should just thank you on behalf of all of us for the work the Hazards Campaign does in keeping campaigning for workplaces to be safe. But over to you, Hilda.
Thank you very much. I can't start my video. It's not working. Can you hear me?
Yes, we can hear you.
Okay, fine. Given the appalling denigration and dismantling of the principles and practices of collective preventative public and occupational health by the UK governments during COVID and recasting it as to meet government ideology as just personal choice actions, how can public and occupational health rebuild to deal with COVID, because it's not going away and it's not going to be solved by these personal choice actions, to deal with COVID, monkeypox, and all the other health crises we face by, regaining the reputation and trust and need for collective preventative principles and measures?
Wow, another really meaty question that goes to the heart of how we've dealt with COVID. Who wants to take a stab at answering one part of this rather than the whole? Don't expect anyone to come up with the definitive answer, but there are a number of responses I'm sure that we can provide. Who wants to talk about workplaces and the denigration of the history of occupational health and public health in this country, which I think Hilda is what you're talking about?
Yes.
Kit?
I won't try and propose solutions because I think many of the solutions that we've suggested in the past have been ignored. What I will instead suggest is that you're absolutely right in that we've seen messaging from the government saying it's time for people to take personal responsibility in the face of COVID. And at the very same moments, we've seen the tools that are required to take that personal responsibility being taken away from people. So we no longer have free testing, which means that people who are already suffering cost of living crisis are not going to go out, and buy tests. They're not going to test, they're not going to know when they're infected. Consequently, they're not going to isolate. There's no more support for people to isolate when they're infected. We have some of the worst sick pay in Europe at the moment. Boris Johnson said, well, we need to take a leaf out of Germany's book. When they're ill, they stay at home. And he's absolutely right, they do. And the reason for that is because they have significantly better sick pay than we do in the UK. The other things that we could be doing are better messaging about what to do when you're infected, improving the symptoms list, offering boosters to people, all of these things which genuinely would allow people to take some personal control of their own COVID situation, we're not doing. And I suppose the other thing is that, of course, you don't solve this problem on your own. This is a collective problem, and nowhere more clearly is that evidenced in our attitudes towards masks. Of course, you can wear your own mask and that protects you to some degree, but what is better is if everyone in a closed indoor environment is wearing a mask, because it reduces the amount of virus in the air. It doesn't just protect you, it protects everyone around you. And again, the messaging around masking has been so poor in the country that many people don't know this. We regularly get people on Twitter saying, well, you mask if you want to, you know, don't impinge on my life. But that's not quite how it works. Collectively, we can have much better solutions than we can individually. You know, the sum is much more than the whole is much more than the sum of its parts in this situation. But yeah, I'm sorry that I don't have any solutions to this problem.
Thanks, Kit, but raising, and we will have, I'm sure, more questions around masks. So more to that. So Steve, Raisha, and then Susan.
So, I mean, first of all, you're absolutely right. To talk about personal responsibility is absolutely meaningless unless government takes its own responsibility seriously. And with Susan and Robert West, we published something just the other day in British Medical Journal making the point that how can people take responsibility for keeping themselves and others safe if they're not given information about the nature of the risks, information about how to mitigate them, and support. And Kit has pointed to the obvious example, which is it's all very well to tell people to self-isolate when they are ill. And indeed, that's what Boris Johnson told people to do when they can't afford to do so. And sick pay in Germany is 100% of your wage. In this country, it's 18% of your wage. So absolutely, personal responsibility means nothing and is hypocritical unless government takes their responsibility seriously. Now, in terms of what we can do, I think we do have to acknowledge that the likelihood of government doing anything right now is very low indeed. And given they're spending their time trying to outflank each other to the right, the leadership candidates are not taking anything to do with health seriously. There was a fascinating piece yesterday in The Guardian with the journalist saying he'd had 41 press releases from Liz Truss. Not one mentioned the NHS. 36 from Rishi Sunak, of which only 3 mentioned the NHS, and one of those was to say that people should pay more and they should be fined if they don't go to appointments. So the government is doing nothing. But as you will know, because the Hazards are one of our key supporters, the Pledge campaign is beginning to say that if we cannot ask government to do things, we can do things for ourselves. That unions, workers, customers, vulnerable people can go to employers and ask them to sign the pledge, which is a commitment in general to take health and safety seriously, to enter into discussions about how to be COVID safe, and particularly not to require people to go to work if they're infected. And it's growing. Just this week, for instance, Unite, the biggest union in the UK, has become a pledge supporter. Doctors in Unite support it. The BMA support. I could go on for a long time. And we will be launching big campaigns in the autumn. So I would say support the pledge campaign. That's something where we ourselves can act collectively to keep ourselves safe, even if we have to be somewhat skeptical about the willingness of government to do it.
Thanks. Great point, Stephen. And to Susan.
Yeah, completely agree with what others have said. But with occupational and public health, it's absolutely key to think about the environment. You know, it's about safety at work, safety where people live, safety where people play and have fun. And that's all about the infrastructure. Not all about, but a lot of it is about infrastructure. And, you know, we shouldn't have to have masks, you know, if all our buildings were well designed, well ventilated, if society was organised so we could be outside as much as possible when needed, etc. So I think that when we think about occupational and public health, I think we have to think about the interaction between the environment and people. So, for example, if we want to keep cyclists safe, we don't just say, we'll give you some information and we'll teach you how to ride safely and keep away from the cars. We actually change the infrastructure. So we have different lanes where cars can't crash into people. And we should think about designing our workplaces, our homes, our cities, etc., with that in mind. And it's a very, very different mindset than unfortunately the current government have. But we just have to keep raising that concept, that way of looking at things. And, you know, just saying that we have to keep not only investing, but also thinking about it and designing better ways of doing things.
Thank you very much, Susan. That was a very good response. And I'd just add, Hilda, that in addition to encouraging you and the Hazards Campaign to work with us individually as well as a group in future in your campaigns, that that we really in the complicated changing structures of public health within the UK, we're witnessing the loss of a whole lot of expertise, global leadership in the area, and I think it's and of course this speaks to a political as well as a health and social care agenda, but it is really important that we refashion, for the future, a much stronger infrastructure. So thank you very much for your question, Hilda. Let's move on to Lynn. If Lynn is, I think Lynn is here. If you sort of unmute and if you can turn your camera on, Lynn, who I think you're asking a question on behalf of a friend, but nevertheless, please go ahead and ask the question.
Thank you very much. So what we'd like to ask is, what are the risks versus the benefits of vaccinating a child who has already had a COVID-19 infection, and in particular considering issues such as deaths, hospital admissions, reinfections, which obviously have a big impact on school absences, and long COVID rates?
Wow. So again, a question asking for some complex analyses to be done, and of course this is ever-changing risks as well over time. So it's a complicated question, but who would want to take a stab at this? Steve?
Right. This is a very, very important question, Lynn. Thank you for asking it. I think there are some real difficulties here because we've had some confused messaging around childhood vaccinations. And as Duncan showed us at the beginning, 11% of our children having had a vaccine really is appalling. And you do wonder why. And I seem to remember, especially when the younger age group, the 5 to 12s were rolled out earlier on this year, the Health Secretary said this is a non-urgent vaccination program. It's optional. It doesn't really matter if you do that. And yet this was the one that JCVI fully supported without any kind of hesitation whatsoever. However, in the 12 to 15s and the 18s above and all the rest of it, they were less certain. Certainly the 12 to 15s, they deferred their decision to the Chief Medical Officer, who then approved it based on societal impact and things like long COVID and things, because they're not always given to JCVI as part of their brief. And there is this long-running narrative that because children are less likely to experience severe disease acutely from SARS-CoV-2, that this shouldn't be something that we should worry about. And there have been mentions of, well, look at polio, isn't this something we should be more worried about? And I think it comes back to what we were just talking about actually with Hilda in terms of population scale risks, because everybody understands that people get knocked over on the roads, for example. And yet, if you cross a road in the morning, does that mean all roads are safe? No, it doesn't. And one problem with this individualized healthcare approach that the government's taken is that we're focusing very much on individual risk. And the chances are we may well not know any children that have become very unwell with SARS-CoV-2, but the fact is they do happen. And it's always the case that these sorts of policies apply to most people. So it's very clear from JCVI analysis and of course other healthcare agencies across the planet that vaccinating kids is absolutely of benefit across the board per se in terms of risk of deaths and hospitalizations. Those analyses have been done. I'm not going to reproduce those here. JCVI have also agreed with the majority of them. The question that you put though of when a child has already been infected is an interesting one. And I think nowadays with Omicron, it's especially important. I don't think that there's really a risk of any kind of danger to the children having a vaccine after they've been infected. There is a government remit that you have to wait 12 weeks or 8 weeks after you've had an infection, if you're able to test for it, of course. But really one reason looking forwards is that we don't know what's going to be around the corner. So Duncan said rightly that there isn't an obvious new variant coming at the moment, but we don't know what's happening. And the advantage of our vaccines is that if you think about the differences between the different sorts of SARS-CoV-2s, the original one from China was kind of in the middle, Delta was over here somewhere, and Omicron was over here somewhere. And so an infection with Omicron really only protects you, and very poorly, actually, especially in children, the immune response isn't very good against those Omicron strains. So if you want to have protection going forwards for the future, it really is advisable to have those vaccines which sort of recenter your immune response almost. They may not last forever in terms of protection from infection, but they certainly are important in terms of reducing severe illness. That does apply to children. It reduces the incidence of something called MIS-C, which is a horrible inflammatory complication that younger children can have. And there is also, if you base it on adults, a good chance that vaccinations will reduce the chances of long COVID, which of course can happen whether your initial infection is mild or severe. So I would absolutely say that yes, we need to get our children vaccinated. And I think the messaging that's been put across around this has been appalling, in my view.
Thank you, Steve. Very well put. Zubaida.
Can I just add that one of the worst things that's happened because of the way children's vaccinations have been underplayed is that it has had a disproportionate impact on particular groups of children. And this is one thing that we just don't acknowledge. Whenever we talk about children, we talk about them as though they were this one homogenous group, and they're not. They're just like adults. They come from deprived backgrounds, they come from vulnerable households, they come from overcrowded households. So the same risk factors that we paid attention to for adults, we're completely ignoring for children. And it matters. It matters when children are being exposed again and again and again, because the Department for Education have taken very few mitigations, very few actions in schools to reduce the risk of exposure for children. And the other thing that matters is we know that around 1/3 of children in primary and secondary school are from Black and ethnic minority backgrounds. We saw the figures from Duncan, where he was talking about excess deaths being disproportionately among Black and Asian groups. We've known that about COVID. We've known that about hospitalizations, that Black and Asian groups are disproportionately more likely to be hospitalized. Now, children are also vulnerable, and children don't live in a vacuum. They take the virus back home. So actually, it was reckless and it was immoral not to push vaccines out much more for children and not to place a priority there.
Thank you very much, Zubaida. That's a really important point. So, Lynn, hopefully you've got a selection of views there from our panel. A complicated question, essentially important question, but nevertheless, I think you've got the message here of the burden of advantage of vaccination in children, as JCVI does recommend indeed. So thank you very much for your question. If we move on to, this is a question that I'll read out. It's a long question. So what I propose, I'll with many different parts, I'll read it all out, and then maybe we can just go round the panel on each individual point, and succinct answers would be welcome. So the question is from David Magna, who asks, has Independent Sage looked at the evidence of the potential harms of prolonged mask use, including but not limited to increased risk of bacterial infection due to mask contamination, the risk of reduced blood oxygen saturation on learning, cognitive function and development, risk of opportunistic infections due to reduced immune system efficacy as a result of prolonged mask wearing, social and mental health harms of prolonged mask wearing. And then as follow-on supplementary, having looked at all the potential known harms of prolonged mask wearing, are the members of Independent Sage satisfied that the risks to children posed by possible COVID infection outweigh the potential and known risks to children of prolonged mask wearing? So complicated question with multiple there. I should say to David and the public listening, asking whether we've done analysis and we're aiming to do that. We are a group of individuals with day jobs. Many of us are academics, but not all, who are involved with their own research in their own area. We don't have the capacity to commission research either. So the answer to this is not going to be what an Independent Sage analysis has done, but rather from our experts on the panel, their reading of the literature, as well as sort of understanding of the biology and spread and transmission of COVID to inform their answers. So that's what we can provide. We can't provide anything more than that. So starting with who wants to take what the increased risk of bacterial infection due to mask contamination? Trish.
Yeah, I can take that. Yes, masks can become contaminated with the microbes that are in our mouths. And someone, I think it was David, sent us a paper that was published last month in which just over 100 volunteers kind of handed in their masks, and they were analysed and found to contain the kind of bacteria and fungi that would be expected to be found in a mouth. Now, that's not very surprising, since everyone's mouth contains microorganisms, and those microorganisms are mostly harmless. They're friendly bacteria, friendly yeasts, and things like that. They may occasionally cause a problem. It's also not very surprising that the longer you wear a mask, the more likely it is to have microorganisms, and the more microorganisms are going to be there. That's why you need to change your mask regularly. If it's a washable mask, you wash it. If it's a disposable mask, you replace it. But you won't get infected from your own mask, because those bugs came from your mouth. And I suppose the really important take-home point here is don't share your mask. Wear your own mask, but someone else can wear theirs. It's the same as don't share your toothbrush, really. It's yours. So that's the answer to that one.
Great, Trish. Very clear and a compelling description of the normal flora that's called in our bodies. Thanks. The next item, the next question, what's the risk of reduced blood oxygen saturation? Which one, of course, the assumption here is that mask wearing does reduce blood oxygen saturation on learning, cognitive function, development.
Yeah, I can do that one too. And actually, this is one in which my team have actually done some primary research. We've done a randomized controlled trial, which I don't think is quite out, but also we've had a look at trials and studies done by other people. And we can confirm, but I can confirm based on my own research and on the research in the literature, there is absolutely not one shred of evidence that masks reduce the blood oxygen level. Oxygen's a tiny molecule, it goes through the holes. Especially if you're wearing, one of these standard FFP2 masks, which has been designed for breathability. But what does reduce your blood oxygen level is a bad attack of COVID-19. So what we need to do is prevent people getting COVID, because a very small fraction of people, but an important fraction, are actually going to come to a lot of harm from low blood oxygen levels due to COVID.
Yes, absolutely. Thank you very much, Trish, for that. The third is, first of all, again, the assumption underlying the question is that mask wearing in some way compromise your immune system, and will that lead to more opportunistic infection? Who wants to just deal with that? Quite a straightforward question. Yes, Steve.
I believe this probably relates to the idea that because, and it's been banded around the sort of with the hepatitis outbreaks, and the idea that we're not exposing children, I think is what the focus is probably about, to diseases they would otherwise have in childhood, and that this somehow causes an immune deficiency. And this is a sort of really strange twist on sort of the hygiene hypothesis, which was kind of the idea that you need to get mucky and infected with lots of things when you're young in order to become immune to things when you're older. And there is an element that it can change the outcome of an infection depending on what age that you get infected at. So for example, if you get EBV, the virus that causes glandular fever, as a teenager you get glandular fever. If you get it as a child, you don't tend to get very ill. So there are changes in our immune systems, but to say that we then have an immune deficiency because we're not exposed to flu for a year or two, for example, which is exactly what happened during the pandemic, really isn't the case. And it depends if you're looking at the individual level or the population level. The population level, yes, there may be more susceptibility there, but in the individual level, we're still able to make those immune responses. Our immune systems are pre-programmed with the arsenal to fight these things. And of course, the best way to pre-arm our immune system is to vaccinate people, not to expose people to infection. The idea that you can allow infections to just pass through and cause harm is something that has been out of date since the first smallpox vaccine was given. So I don't understand the rationale for that. There is no evidence that immunodeficiency follows from taking masks on or off, I'm afraid.
Thank you very much, Steve. Again, very, very clear. And then the last question, which again, there's great expertise around the panel, so expect to get some good answers here, is the social and mental health. The prolonged mask use associated with social and mental health harms. Who wants to talk to any evidence that would support that as a statement? Yes, Steve.
So first of all, I'm really pleased that we are raising the issue of mental health, because I don't think we do so enough. And the issue of mental health is massive, as important, I think, as physical health. And a study recently by the Prince's Trust showed that 48% of young people said they had mental health problems, and 46% said that their mental health problems have been increased by the pandemic. So clearly, the relationship between the pandemic and mental health is absolutely critical and should be central to our considerations. The issue, however, is what causes those mental health problems. Is it the pandemic itself, or is it the response to the pandemic? And many people will point to things like the responses as the problem, and masks are seen as part of that. The evidence, however, seems to suggest that actually the major causes are the pandemic itself. It's the fear and anxiety about getting infected, or a parent being infected if you're a child. The trauma if somebody does get infected, goes to hospital, is put on a ventilator or dies. The anxieties about what the implications will be in terms of your future financially, if nothing else. So there is little doubt that the major cause of mental health problems is the pandemic. And to the extent that masks are effective in lessening infections, and I think the data is pretty clear that they are, including in schools. In fact, there was a very interesting study that came out just last week in Boston showing that in a university setting, so still young people in a university setting, if people were vaccinated, if they wore masks and if there was ventilation, there was virtually no transmission in class. So very effective mitigation. Indeed. Now, when it comes to masks themselves, as I say, the strong argument, I think, is that in lessening infection, they improve mental health, because infection and the pandemic is bad for mental health. There are arguments that, however, they do have any other effects. And one of those arguments, one of the clearest and strongest arguments, is, well, they impede emotional development, because you can't see people's expressions. Now, there's very little data on this. One study, which has been cited quite a lot, uses photographs of people, static photographs of people wearing a mask or not wearing a mask, and then asking if you can glean their emotions. And not surprisingly, you can glean their emotions more if they're not wearing a mask. But it misses the point that normally people are in movement, and we can glean their emotions by the ways they move, by the way they move their eyes and so on. So there's very little data indeed to show that there are actual harms. Very little data indeed, and I've searched systematically through the literature, very little evidence indeed that masks increase anxiety overall. Of course, they have different implications for different people. Some people, they will make some anxious. For some people, not wearing masks will make them anxious. So to sum up, I would argue that the present state of the art is that masks overall, insofar as they deal with COVID, are good for mental health. There is no clear evidence they do harms, but I would say two things. Number one, we should continue to do that research and keep an eye on it. And number two, we need to take individual circumstances into account and think of creative adaptations, like, for instance, transparent masks, through which you can see people's emotions. As I say, overall, I would argue that masks actually are good for mental health because they help deal with COVID.
Thank you again, Steve. That's great. Yes, Susan.
Yeah, just a very brief postscript. Whilst all that's true, we do need to remember that people are very different. And there are quite a few people who are neurodiverse in various ways. And for them, having tactile material on their face is extremely aversive. So for a very small proportion of people, it can really cause distress. And I think that's why it's really important to think of it as a population-wide measure, but also recognise diversity and difference and be able to have ways of communicating where that's the case, so that there's no stigma attached to people either wearing a mask or not wearing a mask if it's problematic for whatever reason.
Thank you very much, Susan. So the last component of this question it addresses, I mean, we've touched on children in terms of risk benefit of vaccination. Here is really the question is the risk benefit of mask wearing. Are we satisfied the risks to children posed by possible COVID infection outweigh the potential known risks to children of prolonged mask wearing? So on top of the sort of the answers that we've had so far, something specifically around children, who wants to just briefly address that? Trish?
Well, I think we've covered a bit of this earlier, particularly in what Susan was saying. Look, nobody wants kids to wear masks everywhere. Nobody wants them to wear masks forever. And I think we need to take a whole of society view of this. One way of making masks less important in the sort of chain of prevention is attend to all the other things that we need to do to get the levels of COVID down, making sure that the kids are fully vaccinated. And we saw the evidence today in those slides that a big proportion of kids haven't been vaccinated yet. We need to make sure that the classrooms are well ventilated with the air filters if necessary, and to make sure that if people have got symptoms, they're tested, positive cases stay at home until they're no longer contagious, all those kind of things. And if we pull all that together, the levels of COVID are going to be much lower, and there will be less need for kids to wear masks. I'm not sure that we'll be able to eliminate entirely, but I think what we want to get to is a situation where most of the time they don't need to wear masks, but when those cases rise and we're in the peak of a wave, the masks are reintroduced temporarily. So that's the kind of thing that you know, for example, the pledge is oriented for, is making our public buildings much safer.
Thank you very much. Steve, we want to get through some more questions.
I'll be very brief, Deenan. I think it's a really important point, and I think people try and paint us sometimes as being pro-mask. Actually, we're not pro-mask. We're anti-mask. We're strongly anti-mask. We want to create the conditions where masks aren't necessary because nobody wears them for fun. So we want to bring down infections through a range of measures so we don't need masks. But as long as rates are high, it is better to wear a mask than to get COVID. And that's true for children as well as adults.
Great, thank you very much. Okay, so that's a really comprehensive set of answers. I want to touch on two more questions. One, I'm going to take myself because it's very easy answer, very straightforward answer, but nevertheless it's important message. So Craig asked, my wife is clinically vulnerable. We've been shielding since the onset of the pandemic, feel our health is suffering as a consequence. We're considering venturing outside for a walk, but are reluctant to wear masks for fear of abusive comments. Our question is with the Omicron variants, how safe is it to walk past other pedestrians in the street or local park? I think it's fair to say that really the benefit of being outside and maybe walking past people in the park, in the outdoor, the benefits of that far outweigh clearly the costs of staying at home and your mental health. The risks is very low to get infected outside, other than within sort of mass gatherings and so forth. So just walking past people in the street is very low risk. So please, our advice, speaking on behalf of the group, is please get out and enjoy the weather that we now have. I've one more question from Flora. I would like to know if the nitric oxide nasal spray looks like a promising way forward to prevent infection. The company Sanitize, which is the company that is branding this for a treatment, proposed its future use 3 times daily to prevent infection ever taking hold. But I can find very little about this in clinical trials. Does the panel think it holds realistic promise as a viable preventive measure? If so, what's a realistic time scale for it to become available in UK pharmacies? Does anyone want to take this? Again, I'm happy to comment. Why don't, in the absence of why? So I'm aware that there's a couple of randomized controlled trials, which are good trials, which have shown that that this spray 3 times a day in infected individuals reduces the time period over which shedding occurs and can reduce the time of shedding and therefore infectivity to a few days by a few days compared to someone who gets placebo. It is available over the counter. However, it's a very different question to ask about whether it be used in a preventative way, and I'm not aware of any trials that have addressed that. In other words, of those who are at high risk to take nasal sprays 3 times a day in order to prevent an infection. Does anyone else in the panel have anything to add to that? Yes, Steve.
Yeah, just completely agreed. And the question of protection and prevention and prophylaxis is a difficult one, and there haven't been many trials looking at that. There are these sort of equivalents of the sort of first defense sprays as well, kind of polymers, which essentially bung up your nose, but from a virus's perspective, not from your perspective, you can still breathe. They are effective, but you have to be really careful with the timing in which you apply them, and I think you probably have to keep applying them regularly for them to be effective. So it's probably the same with this. I think prevention, if prevalence is high, is far better achieved by wearing a filtering mask than through these sprays, I'm afraid. You're muted, Deenan.
Sorry. Thank you very much, Stephen, and thanks again for the question. That's a new sort of potential therapy, but hopefully that's made things clear. So we're out of time now. We did wonder how many questions we would get, but I've had to miss out some questions. Apologize for those of you who put in questions that we've not been able to read out. Some of those we have definitely dealt with in previous sessions, so hopefully you've heard or can go back and look at our previous YouTube presentations and briefings to see those answers. So that's all we have time for. So thank you, the public, and as always, I would like to thank our panel of experts. I think that expertise and that analytical expertise really came to the fore today, and we're very, very lucky to have such a group of individuals willing to give their time. Before we break, I just want to announce that IndieSage has taken a bit of a break itself. For 2 to 3 weeks, we will be on social media, announce when our next session is going to be in early September. But till then, please keep safe, and we'll all see you soon. Goodbye.
Bye.
Bye.
Cheers.
Bye.